Okay, I'm going to be recording Final Frontier NPTE Prep Day 27, March the 5th to 2020. Wound healing and ulcers in the O'Sullivan text. Final Frontier uses the 6th edition. I use the 7th. The 6th edition is not available in ebook. The 7th is. And then we'll move on to Therapy Ed. So, this is the O'Sullivan book. Those are the pages out of the O'Sullivan book. This is my 7th edition. And these are the pages that I will have my reader read. And then we will move on to skin ulcers from Therapy Ed. Okay. So let's pull up the book and start the reader.
Wound physiology. Normal wound healing in the human body. An elegant sequence of events takes place to ensure that when injury occurs, wounds will heal within the endogenous fluids of the body. Every cell and chemical mediator is programmed and ready to act when needed. When conditions are normal, the body is equipped to heal itself. Phases of healing. The classic model of overlapping phases of wound healing describes a process that is continuous, its phases not entirely distinct. The model is used in this chapter to draw attention to the normal process and to provide guidelines for what can be expected in normal healing. The number of days to complete each phase will vary based on factors such as age, size of wound, comorbidities, continued trauma, nutrition, blood flow, medications, stress, and infection. The process of repair is the same for all wounds, but the sequence will be much quicker in more shallow wounds with less tissue loss. In all stages of healing, wounded tissues are striving to achieve homeostasis. Italicized words below stress important concepts during each phase. Inflammation phase I. The normal immune system reaction to injury. The central activity in wound healing. Temporary repair initiated by coagulation clotting factors, platelets, and short-term decreased blood flow. Necrosis occurs after cells have been injured or destroyed. The spread of pathogens is slowed. Debris and bacteria are attacked by a host of cells. If the wound is acute, some peri-wound edema, erythema, and drainage can be expected. If fluid accumulates at the injury site, it is called pus. Oxygen is delivered via increased blood flow to keep the phagocytic cells alive and functioning. Permanent repair is facilitated by creating a clean wound, setting the stage for the next phase of healing. Signals are generated that reepithelialization can begin. Time frame: day of injury to approximately day 10. Rate of inflammatory process is affected by the size of the wound, blood supply, available nutrients, and the extrinsic environment. If this phase is interrupted or delayed, chronic inflammation can result, lasting for months to years. See the abnormal wound healing and the chronic wound section. Proliferation phase 2. New tissue fills in the wound as fibroblasts secrete collagen. Skin integrity is restored by reepithelialization and or contraction. See discussion below. Angiogenesis occurs. New blood vessel growth from endothelial cells and fragile capillary buds grow into the wound bed. New reddish, slightly bumpy tissue is called granulation tissue. Epithelial cells differentiate into type I collagen. Collagen synthesis occurs, but the resulting new scar tissue is fragile and must be protected. Trauma during this phase may return the wound to the inflammatory process. Time frame: day 3 of injury to approximately day 20. Rate of proliferation is affected by the size of the wound, blood supply, available nutrients, and the extrinsic environment. If this phase is interrupted or delayed, the result may be a chronic wound. Maturation remodeling. Phase 3. Maturation or remodeling of new tissue begins while granulation tissue is forming during the prior, proliferative phase. Epithelial cells continue to differentiate into type by collagen. Common new skin has tensile strength that is 15% of normal. Scar tissue is rebuilding but at best reaches 80% of original tensile strength. Underlying granulation tissue is replaced by less vascular tissue. In deep wounds, dermal appendages are rarely repaired. Hair follicles, sebaceous and sweat glands, nerves, but instead are replaced by fibrous tissue. Over time the scar tissue matures, changing from red to pink to white and from raised and rigid to flat and flexible. Time frame, approximately day 9 of injury up to 2 years. Rate of maturation remodeling is affected by the size of the wound, blood supply, available nutrients, and the extrinsic environment. The role of oxygen in wound healing. The need for oxygen to sustain life is apparent, not only at the systemic level, but also at the cellular level of human physiology. Oxygen reaches the wound bed through blood flow to the area. When oxygenated blood flows to the tissues of the body, it is called perfusion. Wound contraction, collagen deposition, angiogenesis, and granulation are examples of wound healing steps supported by oxygen perfusion. As a safeguard, most cells in the wound environment have an enzyme that converts oxygen to a form that allows the cell to support wound healing. Wound tissue oxygenation or perfusion is so important that it is a sensitive indicator for the risk of post-operative infection. A decrease in oxygen availability in any type of wound results in increased likelihood of infection. Wound perfusion may be limited for a variety of reasons, but the two most common problems are edema and necrosis. The presence of edema and/or necrotic tissue can make it more difficult for oxygen to reach the wound. Since compression can reduce edema and debridement can reduce the presence of necrotic tissue, these procedural interventions are important components of most wound care, unless contraindicated owing to arterial disease. Compression and debridement will assist wound oxygenation. Peripheral vasoconstriction can also limit wound perfusion. Problems with vasoconstriction cannot always be improved readily. Interventions that will increase wound perfusion and are appropriate for all individuals include keeping the wound area warm, avoiding smoking, hydrating the individual, and controlling pain and anxiety. Improvement of oxygen levels in wound tissue alone may trigger wound healing. Adequate oxygen levels will also enhance the effectiveness of growth factors and a host of other cells that require oxygenation to maintain their function. The delivery of exogenous oxygen will be discussed later in the chapter in the hyperbaric oxygen therapy section. The nutritional status of the individual, as discussed below, will also have an impact on oxygenation since hemoglobin, iron, vitamin B12, and folic acid are needed to enable red blood cells to carry oxygen to healing tissues. The role of moisture in wound healing. In the past, the goal of wound care was to create and maintain a dry wound, packed with dry dressings, dried by heat lamps, and exposed to the air. Modern wound management is based on the concepts of creating and maintaining a moist wound environment to facilitate wound healing. More than 50 years ago, research confirmed that a dry wound creates an environment that is hostile to wound healing. A dry wound allows the formation of wound scab and eschar, which inhibit migration of epithelial cells, provide food for pathogens, and affect blood flow to the wound bed. A dry wound also allows cooling of the wound surface. Without a protective barrier, the surface temperature of the wound is decreased and healing is slowed. Adhesion of gauze or other dry dressings to the wound bed causes trauma to the wound bed and pain to the individual upon removal, as the wound breathes through evaporation or by the removal of dry dressings. The rich endogenous fluids that contain the elements necessary for wound healing are significantly decreased and lost. Wound management experts agree that adequate wound hydration is the most important external factor responsible for optimal wound healing. Wounds are typically covered with an occlusive or semi-occlusive dressing. This type of dressing is also called a moisture-retentive dressing because it retains fluids on the wound bed. There are many types and styles of dressings that will facilitate a moist environment. See the dressing section for further discussion. Maintaining a moist wound with an occlusive dressing should hold an appropriate amount of endogenous fluids on the wound, preserving the cells needed for healing and keeping them in contact with the wound bed. Some chronic wound fluid may contain substances that can delay healing, so a balance must be maintained between moisture and exudate removal. Moisture softens wound scab and eschar. Under the right conditions, the body's own enzymes will dissolve the eschar in a process called autolytic debridement. Occlusive dressings help to maintain the appropriate wound surface temperature to prevent delays in healing and to protect the wound surface from trauma and from bacteria and other contaminants. Basic principles of moist wound healing include covering the wound with a barrier, occlusive dressing that preserves adequate wound hydration, limiting fluid loss from the wound surface while the dressing is in place, allowing gaseous exchange, maintaining peri-wound integrity, controlling heavy exudate, and removing the dressing when exudate begins to leak out from edges of dressing. It has long been believed that occlusive dressing should not be applied over infected wounds because trapped bacteria could fulminate. Studies have produced evidence that the opposite may be true in many cases, because in acute wounds, and some chronic wounds, endogenous fluids have bacteria-fighting chemical elements. Evidence of colonized bacteria in the wound does not automatically preclude the use of occlusive dressings. Specially selected dressings such as hydrocolloids are a good choice in this situation. With the use of a systemic antibiotic and a close watch for signs of change in the patient's symptoms, clinicians may be able to utilize occlusive or moisture-retentive dressings over some types of wounds that are infected. The use of this dressing technique may broaden if the evidence continues to build in strength. Meanwhile, there is ongoing investigation into the contents of chronic wound exudate and its power to break down growth factors and prolong the inflammatory phase of wound healing. Information on this level should guide the use of occlusive dressings in the chronic wound healing environment. Despite half a century of research to support the concepts of moist wound healing, there are still practitioners who ignore the evidence and utilize outdated methods of wound management. Clinicians must strive to educate patients, families, and all members of the wound care team about appropriate wound care concepts. The role of nutrition in wound healing. It is well established that nutritional status can have a significant impact on wound healing. Adequate protein intake is required for collagen synthesis, as well as the formation of new blood vessels and muscle tissue. Literature abounds with information about important nutritional issues such as the role of specific nutrients in wound healing, how poor nutritional status can delay wound healing, the use of special pharmacological interventions, and appropriate routes for nutritional support, enteral versus parenteral. Newer literature supports the classic understanding that the function of nutrients is crucial to wound healing. Issues related to wound healing and nutrition are important across the lifespan. Pediatric patients in long-term care, recovering from surgery, or with wounds, burns, or trauma are at risk for pressure injuries. As with adults, adequate protein intake is essential for healing to occur on time. Another patient population of concern is the elderly, whose tissues are fragile and whose immune systems are easily compromised. Nutrition plays a role in the prevention and management of pressure injuries in this population as well. Nutrients that must be present for a wound to close and heal on time include iron, vitamin B12 and folic acid, essential so that red blood cells can deliver oxygen to tissues. Vitamin C and zinc, essential for tissue repair. Vitamin A, essential to stimulate collagen cross-linking. And arginine enhances healing and immune function. High protein intake provides the amino acids required to build new tissue. Protein and calorie needs will vary depending on the size of the wound and the medical condition of the patient. In response to the available information and the need for more research, Nutrition and metabolic support of acutely and chronically ill patients is emerging as an important branch of medicine. As a part of the wound care team, a physical therapist will make contributions to the plans for nutritional support of the patient. Clinicians will collect data through medical record review, observation, history taking, and the use of dietary examination methods. Because exercise, hydration, and improved appetite often are interrelated, a physical therapist should pay close attention to a patient's activity level, strength, conditioning, and mobility issues while encouraging fluid and nutrient intake. Wound characteristics. Wound characteristics describe the physical appearance of the wound but may also provide the clues to the cause of the wound, the phase of healing, and likelihood of closure. The characteristics of wounds may be defined as dry, wet, or granulating. Wounds can also be defined by their etiology, such as diabetic, vascular, or traumatic. Wound characteristics can provide valuable information needed to make sound clinical judgments about treatment. For example, the location of the wound may prompt the clinician to select a particular dressing, change patient positioning, or prescribe orthotic footwear. The wound characteristics are described in documentation. They can indicate progress or failure to progress toward closure and healing. Wound characteristics should be identified during the initial examination and then monitored at least weekly during the wound healing phase. Depending on the etiology and chronicity of the wound, some characteristics may not be evident on initial examination but could appear at a later date as complications of the wound healing process. The following are characteristics that should be tracked and documented throughout the phases of wound healing. Location, where on the body, size, depth, width, and length, shape, irregular versus distinct, edges, condition and shape of wound edges, evidence of premature healing, tunneling, undermining, sinus tracts, presence and depth, base, characteristics of the wound base compared to sides and edges, necrosis, scar, slough, amount, color, texture, adherence to wound bed, exudate, amount, color, odor, granulation tissue, presence or absence, amount, location, epithelialization, presence or absence, premature or unscheduled, exposed structures, color and condition of bone, tendon, ligament, periwound area, edema, induration, maceration, pain. Although not a physical characteristic, it is measurable and significant to the intervention. Quantity of bacteria, amount present in a wound. This is referred to as the bioburden. The quantitative biopsy is the gold standard for obtaining a wound culture, but it is not used universally owing to cost, lack of laboratory facilities, and potential pain for the patient. A swab culture is often used as an alternative, but it is limited to detecting surface contamination, not tissue infection. Clinical intuition is also important in determining if infection is probable. The examination will include data about the characteristics that have been gathered using methods such as observation, palpation, measurement, photography, and tracing. A clinician who is new to the wound care team should remember that these are skills that take practice to master. Wound closure. Primary intention healing by primary intention occurs when a healthcare provider closes a wound by bringing the edges together. Approximating the edges can occur through the use of sutures, staples, glue, skin grafts, or skin flaps. For more information on skin grafting, see Chapter 24. Burns. Wounds closed by primary intention still pass through the phases of wound healing but usually in a shorter time span. A wound closed by primary intention that later opens up again owing to maceration or infection has opened by the process of dehiscence. Figure 14.1. Following dehiscence, a wound is almost always allowed to close by secondary intention. Secondary intention closure and subsequent healing by secondary intention occurs when a wound is left open to heal on its own. The mechanisms of healing by secondary intention or contraction, reepithelialization, or a combination of both. Deeper wounds heal by replacing injured tissue with scar tissue as collagen fills the wound bed. Contraction occurs when growth factors trigger myofibroblasts to pull the wound edges inward. During the process of contraction, existing tissue migrates, pulling the wound edges toward the center of the wound. This process forms no new tissue. New tissue may be forming in the wound simultaneously but not via contraction. Growth factors in myofibroblasts can be influenced positively or negatively by physiological factors such as the amount of oxygen and nutrients available, and by mechanical factors such as external compression and the shape of the wound. Even though contraction is a normal occurrence in certain types of wound healing, if it is too rapid, it can cause disfiguring scars and impaired tissue function, since there is centripetal movement of the entire thickness of the surrounding skin. Tissue elongation may not keep up with the pace of contraction, causing significant functional and cosmetic deformity. Clinicians should intervene by applying special types of pressure to the tissues to slow the deforming forces of contraction. Scar management is discussed later in the chapter. Epithelialization is another response used by the body to close a wound. As noted in the phases of normal wound healing, chemical mediators send signals for reepithelialization to begin in phase I, the inflammatory phase. Actual repair begins in phase II when new tissue is formed to cover the wound. Growth factors stimulate specialized epithelial cells, called keratinocytes, to begin to migrate from the edges of the wound toward the center. In partial thickness wounds in which the dermal appendages have not been destroyed, the cells will also migrate from the hair follicles, sebaceous glands, and sweat glands. In smaller, shallower wounds, this process may be triggered to begin as early as 12 hours after wounding. In larger wounds, it may be 10 days or longer before the cells begin to migrate. In a chronic wound, there are many reasons why this process is not triggered or is interrupted. See discussion under abnormal wound healing and the chronic wound. When epithelial cells meet at the center of the wound is covered with new skin, migration ends, and cells will stop dividing. This is referred to as contact inhibition. At the time of contact inhibition or full reepithelialization, wound closure has occurred. Wound healing, however, may continue for several years. A significant amount of intervention is still required to support the wound successfully from closed to healed status. A physical therapist will provide routine surveillance as well as specific intervention for the many possible sequelae of a wound. When a wound is closing and healing by secondary intention, the rate of closure and the physiology of closure are impacted by a number of factors that a clinician will monitor and document. Wound shape, linear wounds, surgical, contract most rapidly, circular wounds, pressure injuries contract most slowly, wound depth, all things equal, the shallower the wound, the quicker the closure. Superficial, loss of the epidermis, closes by re-epithelialization. Partial thickness, loss of the epidermis and dermis, closes primarily by reepithelialization with minimal contraction. Full thickness, loss of all layers of the epidermis, dermis, and deeper structures, closes by contraction and scar formation. However, epithelial cells will migrate from the wound edges to assist in wound closure if the environment is homeostatic. Wound location, areas with least pressure, most perfusion, face, will close more rapidly than areas with most pressure, least perfusion. Sacrum, heel, wound etiology, least traumatic surgery, will close more rapidly than most traumatic pressure injury. Burn, as deeper wounds heal, the wound is filled with tissue but the repair process does not replace lost muscle, fat, or dermis with those same types of tissue. The wound is filled with scar tissue made up primarily of collagen. Because the original tissue is not replaced with more of the same, a wound that is closed and finally healed does not return to its pre-wounded state. This concept is particularly important to understanding the position on reverse staging of pressure injuries as described in the tests and measurements section. It is also important to understand this concept when planning protection, positioning, patient education, footwear, and exercise programs for individuals with all types of wounds, whether they are acute, closed, healed, or chronic wounds. Tertiary intention, also called delayed primary. This type of closure occurs when a wound is allowed to heal by secondary intention and then is closed by primary intention as the final treatment. The delay in primary closure is usually owing to the presence of infection, abnormal wound healing, and the chronic wound when the sequence of events that leads to normal wound closure and healing does not occur. A chronic wound results. The characteristics and causes of chronic wounds vary owing to the diverse nature of individuals with wounds, their medical histories, and the etiologies of the wounds. Even if the chronic wound moves through the classic phases of wound healing, it does so in an abnormal manner. Vital actions and reactions necessary for wound healing are interrupted, stunted, or absent in the chronic wound. Although the characteristics of abnormal wound closure and healing may be varied, concepts can be used to illustrate the failure of a wound to pass through phases of wound healing in a timely manner. The following discussion highlights what may happen if there is an interruption to any of the classic phases of wound healing. Inflammation phase I. If there is inadequate blood flow and oxygen supply to support cellular life and activity, cells may not initiate the repair sequence. Debris and bacteria may build up, and pathogens spread more rapidly. Bioburden, if measured, is greater than 105 organisms g of tissue. The classic definition of infection. Clinical signs: increase in amount of drainage, change in color or odor, lingering swelling, eschar necrosis from ischemic conditions, periwound maceration, chronic inflammation, tunneling, undermining, and infection may develop if the host's immune system is unable to resist the impact of the bacterial load. Proliferation phase 2. If collagen synthesis is delayed in this phase, skin integrity will be poor. If angiogenesis is delayed, there will not be enough myofibroblasts to initiate wound contraction. The need for oxygen and nutrients will be very high, and without them, available cells will be unable to reproduce rapidly, resulting in delayed epithelialization. Clinical signs: keratinocytes do not migrate because the wound bed is not moist, healthy, clean, and granulating. Epithelial cells may attempt to migrate from the wound edges, but without a wound bed that is ready, they will build up at the wound edge and may migrate over the edge, forming a lip that curls under. Granulation tissue is either absent, pale, or delayed. New tissue is weak and breaks down or bleeds easily. Tunneling, eschar, and periwound maceration may be evident. Necrosis, if it has not been removed, will delay angiogenesis. Changes in drainage color, amount, odor, or lingering swelling may signal a return to the inflammation stage. Maturation remodeling, phase 3. If the synthesis and lysis of collagen is out of balance, weakened tissue will break down too easily, or hypertrophic scarring will build up too rapidly. Clinical signs: newly formed skin breaks down with little provocation, or scar tissue may build up within the outline of the original wound. Hypertrophic or beyond the margins of the original wound keloid. Infection and wound healing. Wound infection is a significant problem for any individual. Infection may turn life-threatening if the patient is elderly or critically ill. Regardless of the condition of the individual, wound infection is detrimental to wound closure and healing time. Bioburden has a greater impact on wound healing than most underlying medical conditions. True infection is identified if the presence of bacteria or microorganisms is greater than 105 per gram of tissue determined by a quantitative culture. This determination can only be made with a biopsy. Surface swabs that are cultured may or may not be conclusive for actual infection, since there are many types of bacteria that exist on the skin all the time. Effects of infection. inefficient cellular activity, decreased collagen metabolism, chemical mediators absent or dilute, cells absent or confused by lack of instructions from chemical mediators and presence of other cells. When the bioburden is greater than 105 organisms g of tissue, epithelialization may not occur. Decreased oxygen in the wound bed, insufficient oxygen to support the regeneration of tissue and to assist in the prevention of infection, increased rate of cell necrosis. Overall decline of body systems contributes to strain on the specialized cells, risk of wound sepsis, osteomyelitis, gangrene, signs of potential infection, change in wound drainage, amount, color, odor, swelling, periwound redness or warmth, less obvious with darker skin, increase in pain or tenderness, change in the quality of granulation tissue or failure to produce good quality tissue, may be pale, soft, easily broken down, common no measurable wound contraction within 2 to 4 weeks. Tissue culture punch biopsy results of greater than 105 organisms g of tissue, fever, nausea, fatigue, loss of appetite. Clinicians should use a structured approach to identify clinical infection. Careful identification of infection may help to avoid the risk of overuse of antibiotics. The punch biopsy is the gold standard for confirming infection, but a physical therapist should watch for the early signs of infection: warmth, redness, swelling, fever, malaise, and loss of appetite. Factors contributing to abnormal wound healing. The factors or triggers that may contribute to abnormal wound healing are varied but can be placed into broad categories for better understanding. Most abnormal wound healing will be influenced by factors from all the categories. Treatment intervention that addresses factors from one category and not the others will be incomplete. Intrinsic factors. Intrinsic or internal factors are conditions within the body that may contribute to abnormal healing. These factors relate primarily to the wound and periwound areas, and include aging skin and inadequate blood flow or decreased oxygen supply from an underlying disease. As the integument ages, there is a decrease in moisture content leading to an increase in brittle quality and a delay in the renewal time affecting the stratum corneum. Reedy pegs, undulations between contact layers of the epidermis and dermis, become less functional with increased risk of shearing. Changes in the dermis include a decrease in elasticity, collagen, and mast cell production, along with a decrease in the vascularity and number of pain receptors. Available fat in the subcutaneous layer begins to resorb during aging, leading to a decrease in protection against pressure and shearing. Finally, underlying disease is an intrinsic factor that may affect acute and chronic wound healing. The more common conditions known to affect healing are diabetes, cancer, circulatory insufficiencies, HIV infection, and connective tissue diseases. Extrinsic factors. Extrinsic or environmental factors are those influences that come from outside the body. The medical professionals caring for a person with a wound may be able to moderate the impact of extrinsic factors on the wound environment. Examples of extrinsic factors include the effects of radiation therapy or chemotherapy, incontinence, medication, smoking, recreational drugs, and alcohol. All slow or eliminate cellular reactions needed for healing. Dehydration and malnutrition both slow the delivery of oxygen to wound tissues. Bioburden infection. Healing is slowed by pathogens, necrotic tissue, granulomas, and stress. Negative effects of stress can lead to impaired healing. Iatrogenic factors. Iatrogenic refers to any injury or illness that occurs as the result of medical care. Theoretically, these factors are under the control of the medical professionals who care for the patient and are therefore preventable. Factors include, but are not limited to, poor wound management, frequent disruption of the wound through inappropriate cleansing, use of inappropriate dressings and dressing techniques, use of cytotoxic topical agents that led to inefficient cellular activity, and lack of moisture resulting in delayed or absent migration of keratinocytes. Frequent dressing changes not only disturb the fragile surface of the wound but will also slow wound healing by reducing wound temperature. It can take more than 30 minutes for a wound to return to normal temperature after a dressing change. Infection can be an iatrogenic factor when caused by cross-contamination, improper use of gloves and other protective devices, inadequate use of sterile and clean technique, lack of proper hand washing, and lack of adherence to standard precautions. Other iatrogenic factors that contribute to abnormal wound healing include shear injuries, skin tears that occur during transfers and repositioning, and ischemia from unrelieved pressure owing to inadequate turning schedules or absent or inadequate pressure redistributing devices. PRDs. Complications have chronicity. A chronic wound creates a complex and serious health problem for an individual. Figure 14.2. Chronic wounds may lead to complications, including any or all of the following: impairments of body function and structures, restrictions in activities and participation, need for assisted living and home care, decreased quality of life perceptions, depression, infection, malnutrition and weight loss, protein depletion, tissue fibrosis, loss of limb, and death. Every year, millions of Americans are treated for chronic wounds at a cost of billions of dollars, making this type of wound one of the most costly challenges in healthcare. A chronic wound fails to close and heal because of an underlying pathology and will not progress readily until the cause is corrected or improved. The clinician must determine the factors contributing to abnormal wound healing and then develop an appropriate POC to overcome or address the obstacles. Vascular, lymphatic, and integumentary disorders. Arterial insufficiency and ulceration. Arterial insufficiency refers to a lack of adequate blood flow to a region or regions of the body. Many different disorders may arise from arterial insufficiency and can be classified by a variety of descriptors. For the purposes of this chapter, references will be to arterial insufficiency owing to organic disruption of blood flow to the extremities or to peripheral vascular disease. PVD. PVD is a general term used to describe any disorder that interferes with arterial or venous blood flow of the extremities. PVD caused by arterial insufficiency may be related to smoking, cardiac disease, diabetes, hypertension, renal disease, and/or elevated cholesterol and triglycerides. Obesity and a sedentary lifestyle are related contributors in the cycle of disease and vessel obstruction. When several of these factors are combined, as they often can be, the possibility for health problems is almost 100%. The damage caused by these factors is reflected in structural changes in the walls of the arteries, causing abnormal blood flow. The following is a brief overview of disorders that occur with abnormal arterial blood flow. Arteriosclerosis, thickening, hardening, and loss of elasticity of arterial walls. Atherosclerosis, the most common form of arteriosclerosis, associated with damage to the endothelial lining of the vessels and the formation of lipid deposits, eventually leading to plaque formation. Arteriosclerosis obliterans, a peripheral manifestation of atherosclerosis characterized by intermittent claudication, rest pain, and trophic changes. This is the arterial disease most likely to lead to ulceration. Known risk factors for development of the disease are smoking, diabetes mellitus, hypertension, hyperlipidemia, and hyperhomocystinemia. Thromboangiitis obliterans, Berger's disease. Inflammation leads to arterial occlusion and tissue ischemia, especially in young men who smoke. Raynaud's disease, a vasomotor disease of small arteries and arterioles that is most often characterized by pallor and cyanosis of the fingers. In some cases, both the hands and feet may be affected. The cause of Raynaud's is unknown, but attacks are usually triggered by cold or emotional upset. Ulceration, a peripheral sign of a long-standing disease process. By definition, arterial ulcers are associated with arterial insufficiency. Between 10% and 25% of the ulcers are caused by arterial disease. The incidence of arterial disease and the ulceration is significantly lower than that for venous disease and ulceration. However, arterial wounds more frequently lead to loss of limb and death. These important facts signal the significance of taking a thorough history, performing a systems review, and adequate skin inspection during the initial visit with any individual who might have arterial disease. Clinical presentation. Wounds will most frequently be located on the knees, lateral malleoli, dorsum of feet, toes. When wounds are present on an ischemic limb, atherosclerotic occlusion of the peripheral vasculature is almost always present. The majority of patients with arterial insufficiency also have diabetes. Trophic changes are present and include abnormal nail growth, decreased leg and foot hair, and dry skin. Skin is cool on palpation. Wounds are painful and patient may also describe pain in the legs and or feet. See discussion below about intermittent claudication. Wound base is usually necrotic and pale, lacking granulation tissue. Skin around the wound may be black, mummified, dry gangrene. Other signs of arterial insufficiency will be evident: decreased pulses, pallor on leg elevation, and rubor when dependent. History. Painful cramping or aching of the knees during walking is the most common complaint of patients with chronic arterial occlusion of the knees. The pain is caused by intermittent claudication that occurs when exercising muscles are not receiving the blood perfusion needed for normal function. Patients should be examined for other signs of arterial insufficiency if intermittent claudication is occurring. Rest pain that develops at night, awakens the patient, or requires analgesics for relief is considered more severe than claudication. The individual with vascular dysfunction may also be diabetic. Diabetes will contribute to slower healing times and difficulty fighting infection. A wound in a distal, ischemic area is not likely to close or heal on time unless the vascular supply is enhanced or restored. Individuals with arterial disease and diabetes are more likely to have hypertension and may have previous bypass grafts or amputations of the toes. Pain on ambulation or rest, pain with elevation, cold hands and feet, and color changes of fingers and toes, owing to the long latency period between injury to the arterial circulation and clinical appearance of disorders. Healthcare providers, families, caregivers, and patients must join forces with education, prevention, and vigilance. Tests and measurements. One of the most important screening tests for individuals with arterial disease is performed using a handheld Doppler ultrasound unit to measure blood flow to the knees. The readings are calculated and the end result is called the ankle brachial index (ABI). Results provide useful information about the potential loss of perfusion in the knees. Refer to arterial perfusion in the tests and measurements section under examination and evaluation. Intervention. If ulceration is present, intervention should enhance chemical and gaseous homeostasis in the wound bed, facilitate superficial blood flow to target tissues, and educate patients about the importance of facilitating blood flow to the extremities. Treatment will include appropriate wound care as well as important adjuncts to wound care. Results of the ABI will guide the therapist and referring practitioner in the appropriate use of compression. In a diagnosis of mixed arterial and venous disease, the condition that is more severe should be treated first. If the arterial condition is worse, compression may be inappropriate even when edema is present. A non-healing wound on an ischemic limb can lead to gangrene, amputation, further amputation, and/or loss of life. Figure 14.3. In the most severe cases, conditions are inhospitable to wound closure. Conditions for closing and healing the wound are poor. In this case, necrotic tissue should not be debrided, since the dead tissue will not be replaced with new tissue. Skin grafts may not adhere to the virtually lifeless wound bed. Antibiotics cannot reach the wound systemically, and topical agents are too superficial to stop infection. At this point, vascular surgery may be an option for some individuals. A bypass graft may be used to restore arterial circulation to the ischemic tissue. For others, living with a chronic non-healing wound or coming to terms with amputation are the only options. Most experts agree that the single most important intervention in PVD is prevention of smoking. The second most important intervention is exercise for weight control. Exercise will also improve collateral circulation, lipid profiles, and management of hypertension. A physical therapist plays a crucial role in wound care for arterial wounds and should address patient education and exercise in the intervention plan. Venous insufficiency and ulceration. Venous insufficiency refers to inadequate drainage of venous blood from a body part, usually resulting in edema and or skin abnormalities and ulcerations. Chronic venous insufficiency (CVI) refers to venous insufficiency that persists over a long period of time. The majority of individuals with PVD are diagnosed with CVI. CVI is the most common cause of leg ulcers. In current literature, venous insufficiency is synonymous with venous hypertension, defining the beginning of a chain of pathophysiological events that often end in ulceration. Some authors still use the term venous stasis ulcer, but it has been shown that blood stasis, blood pooling, is not the cause of these wounds, although it is clear that ulcerations are the result of inadequate venous circulation. The mechanism by which this happens is not well understood. Research has focused on how skin breakdown is affected by dysfunction of circulating white blood cells (WBCs), endothelial cell dysfunction, fibrin deposition, edema, and lymphatic congestion. The incidence of venous ulceration is much higher than that of arterial ulceration. Figure 14.4. In fact, 80% of all leg ulcers are caused by venous disease. The higher incidence is not clearly understood even though years of clinical and laboratory research have been devoted to understanding venous disease. The path from CVI to ulceration can take many turns: aging, lack of exercise, obesity, pregnancy, long hours of standing or sitting, heredity, and history of deep vein thrombosis. DVT will predispose an individual to venous hypertension and subsequent CVI. Clinical presentation: swelling of unilateral or bilateral is relieved in the early stages by elevation. Complaints of itching, fatigue, aching, heaviness and involved limb, skin changes including hemosiderin staining and lipodermatosclerosis, fibrosis of the dermis, increase in skin temperature of lower legs. Wounds, most frequently located on the lees, proximal to the medial malleolus, although can occur anywhere. Arterial wounds may also occur at this location, not significantly painful. Usually complaints of minor dull leg pain are relieved with elevation. Granulation tissue is usually present in the wound bed. Tissue is wet from a typically large amount of draining exudate. Signs and symptoms of lymphedema may be present. It is common to see the impact of chronic inflammation and fluid overload as triggers for the onset of lymphedema. History: because the incidence of CVI increases with age, clinicians should be suspicious of the disease in older patients. The slow development of venous disease and ulceration usually implies a history of lingering swelling, slow healing, repeated infection, and frequent recurrence of skin breakdown. Once ulceration occurs, venous wounds can exist for years. This progression of symptoms frequently leads to a mechanical overload of the lymphatic system and subsequent development of lymphedema. If the individual is older than age 50, it is likely there are comorbidities such as diabetes, hypertension, congestive heart failure (CHF), or history of DVT. Owing to the long latency period between injury to the venous circulation and clinical manifestations, healthcare providers, patients, families, and caregivers must join forces using the tools of education, prevention, and vigilance. Tests and measurements: with the exception of mixed arterial and venous disease, the vascular examination results for venous insufficiency will show strong distal pulses and a normal ABI. On palpation, The skin temperature of the lower leg may be elevated. This sign can imply a worsening or impending complication of CBI. The use of instrumentation to measure skin temperature can be invaluable during the examination. Measuring skin temperature will be covered later in this chapter. Existing edema may decrease with elevation unless it occurs in the advanced stages of disease or in combination with lymphedema. With venous disease, pitting edema may occur in the periwound area, the foot and ankle, or anywhere on the body. Advanced edema and lymphedema are generally unaffected by elevation and require compression as part of treatment. However, before adding compression, it will be important to address the possibility of an arterial component to the venous pathology. If there is arterial insufficiency, healing will be impaired and compression may be contraindicated. Results from the ABI will give preliminary information about potential arterial insufficiency, but more sophisticated laboratory tests may be indicated to confirm or rule out arterial disease in the individual who also has venous insufficiency. Intervention. The most important therapeutic measure for prevention and treatment of venous leg ulcers is compression therapy. Compression refers primarily to specialized bandaging and specialized garments, but can also include intermittent pneumatic compression. All of these treatment interventions will be discussed later in the chapter. Even though edema is a natural characteristic of the first phase of wound healing, excessive edema can delay wound healing by slowing perfusion of tissues and facilitating the growth of bacteria. Along with compression and appropriate wound care for CBI, treatment will include exercise to increase mobility and positioning to support and enhance venous blood flow. Compression therapy is essential for timely healing if arterial disease has been ruled out. As mentioned earlier, in a diagnosis of mixed arterial and venous disease, the more severe pathology is treated first. Significant arterial disease will most likely preclude the use of compression for the individual with a diagnosis of venous disease or mixed mild arterial venous disease. A combination of therapeutic measures will accelerate positive outcomes. These include compression bandaging in garments, gait training, manual lymphatic drainage, and exercise, including range of motion, ROM. A wound care plan should not include whirlpool owing to the risks of dependent positioning, cross-contamination, cytotoxic additives, and unnecessary costs. Lymphedema. Lymphedema is a chronic disorder characterized by an abnormal accumulation of lymph fluid in the tissues of one or more body regions. The accumulation of fluid can be caused by a number of events, but is most often owing to a mechanical insufficiency of the lymphatic system. This means that some components of the lymphatic system are not functioning sufficiently to manage the lymph fluid present in the body region. Lymphedema can be classified as primary or secondary lymphedema. Primary lymphedema, figure 14.5, is caused by a condition that is congenital or hereditary. With primary lymphedema, lymph node or lymph vessel formation is abnormal. The most common abnormality is hypoplasia, a condition in which there are fewer lymphatic vessels and they are smaller than normal. One of the more common forms of primary lymphedema appears in Milroy's disease. Secondary lymphedema, figure 14.6, is caused by injury to one or more components of the lymphatic system. Some portion of the lymphatic system has been blocked, dissected, fibrosed, overloaded, or otherwise damaged or altered. Secondary lymphedema is more prevalent than primary. In developed countries, the most common cause of secondary lymphedema is surgery and/or radiation therapy as part of breast cancer treatment. The rise in incidence of other types of cancer and the subsequent treatment for those cancers has led to an increase in reports of lymphedema following treatment for cancer of the prostate, bladder, uterus, ovaries, and skin. Cancer is not the only causative factor for lymphedema. It is common for an individual with CBI to develop lymphedema, triggered by long-standing fluid overload in the knees. Secondary lymphedema can also be triggered by the complications of paralysis, disuse, and chronic regional pain syndrome. or trauma to regional lymph nodes following liposuction, pelvic fracture, hernia repair, and other surgical interventions where lymph nodes or lymph vessels are located. Lymphedema is a common disease, and healthcare providers can expect an increase in the number of patients with this condition over the next decade. Through the efforts of experts in the field of physical therapy, there has been compelling evidence to support a prospective surveillance model as the standard of care in breast cancer treatment. Surveillance includes regular follow-up visits performed by physical therapists to identify and monitor changes that might signal adverse effects of treatment. Studies have shown that this model is more cost-effective than treating the late adverse effects of treatment such as advanced-stage lymphedema. This model should also apply to individuals undergoing treatment for other types of cancer and those at risk of developing lymphedema for other reasons. The collection of data on the incidence of non-cancer related secondary lymphedema is limited by the lack of specific education related to lymphedema among healthcare professionals and by a lack of clinical suspicion when examining individuals with a history of swelling. In the tropical and subtropical regions of the world, secondary lymphedema is most often caused by filariasis. In filariasis, nematode worm larvae live a full life cycle in the lymphatic vessels, causing inflammation and blocked lymphatic vessels. Clinical presentation: swelling distal to or adjacent to the area where lymph system function has been impaired. Swelling usually not relieved by elevation. Pitting edema in the early stages of disease, non-pitting edema in later stages. As fibrotic changes occur, feelings of fatigue, heaviness, pressure, or tightness in the affected region, numbness and tingling as swelling becomes more severe, discomfort varying from mild to intense, fibrotic changes of the dermis, dermal abnormalities such as cysts, fistulas, lymphuria, papillomas, hyperkeratosis, increased susceptibility to infection, at first local to the affected region but often becoming systemic, loss of mobility and ROM, impaired wound healing history. A patient history consistent with lymphatic system damage or deformity will be pivotal in the diagnosis of lymphedema. A patient's history might include cancer, cancer treatment, radiation therapy, lymph node disruption, CBI, trauma, surgery, or in primary lymphedema onset of swelling at birth or puberty. There may be a long latency period between injury to the lymphatics and clinical manifestations. Thus, healthcare providers and patients must adhere to prevention guidelines and be suspicious of any signs and symptoms that might suggest lymphedema. The condition can develop within a few weeks of the initial insult to the system or as long as 30 years later. Phase I, intensive, includes skin care, MLD, lymphedema bandaging, exercise. Tests and measurements for most individuals. The diagnosis of lymphedema can be made without the use of special tests. A patient history consistent with lymph system damage or deformity, a systems review, differential diagnosis, inspection, and palpation of the integument and girth measurements are adequate for accurate diagnosis in most cases. Unique findings might include the Stemmer's sign, skin texture changes, skin folds, fibrosis, increase in girth, papules, lymph leakage, and elephantiasis. Severity is determined by a collection of data, including presence of fibrotic tissue changes, brawny or woody hardened, and a lobular, rounded projection, number of episodes of cellulitis, condition of the superficial integument of the lymphadematous limb, papules, leakage, fungus, venous wounds, circumference or volume differences between involved and uninvolved limbs, and quality of life issue sleep, mobility, activities of daily living ADL, relationships. A non-invasive test called lymphoscintigraphy is a special test using radioactive tracer and a gamma camera to provide images of the lymphatic system. This test is useful for differential diagnosis and to characterize the severity of lymphedema. Intervention. A physical therapist should be cautious about the application of pressure to an edematous or lymphodematous body part. Although compression is an essential intervention, pressures that are too high will occlude superficial lymph capillaries and prevent the initial step of fluid absorption needed to control edema and lymphedema. Current intervention for the patient client with lymphedema requires attention to detail at a level of expertise not often provided in entry-level professional educational programs. Practitioners are best served by gaining additional education to better prepare them to treat these patients. The current recommended course of care is a 2-phase program of complete decongestive therapy, central daylight time, phase I, intensive, includes skin care, MLD, lymphedema bandaging, exercise, and compression garment at the end of phase I. Phase II, self-management, includes skin care, compression garment during the day, exercise, lymphedema bandaging at night, and MLD is needed. A good source of information on training programs or other information on central daylight time, trained therapists, and patient education related to lymphedema is the National Lymphedema Network, NLN, available at www.lymphhnet.org. As with many progressive, chronic disorders, the effectiveness of treatment is significantly improved by early intervention. Accurate and early diagnosis occurs when healthcare professionals are sensitized to the signs and symptoms and carefully evaluate the examination data. In the POC, the number and frequency of treatment should not be determined by lymphedema staging or by circumferential differences between limbs. The severity of the condition is not determined by these data alone. Some individuals with lymphedema may present with more involved signs and symptoms than the measurements imply. The physical therapist should pay close attention to indicators such as a history of cellulitis, brawny tissue changes, and increasing impairment in developing the POC and number of visits needed. Pressure injuries. A pressure injury is a wound caused by unrelieved pressure to the dermis and underlying vascular structures, usually between bone and support surfaces. When pressure is not relieved in time, the damage is of such magnitude that the tissues cannot repair and recover on their own. As deeper vessels are occluded, decreased blood flow leads to cell death, tissue necrosis, and finally a visible wound. The superficial dermis can tolerate ischemia for 2 to 8 hours before breakdown occurs. Deeper muscle, connective, and fat tissues tolerate pressures for 2 hours or less. Thus, there may be significant damage to underlying tissues while initially the epidermis and dermis remain intact. The clinical implications of this phenomenon are discussed below and in the tests and measurements section. Readers can gain greater understanding about depth of damage to the integument by referring to Chapter 24, Burns, to view cross-sections of skin, illustrating which components of the skin are lost at descending levels of damage. Pressure injuries occur most frequently among individuals who are immobilized for long periods of time. Although pressure injuries can occur at any age during prolonged periods of immobility, they are more likely to occur on individuals who are hospitalized, elderly, incontinent, and/or underweight, and among individuals of all ages following spinal cord injury. C. Up to 25% of hospital-acquired pressure injuries may originate during surgery. According to Reed et al., the presence of low albumin levels, confusion, and a do not resuscitate (DNR) order are also pressure injury risk factors. Pressure injuries increase the risk of death for elderly individuals whether at home or in a hospital or long-term care setting. In developed countries, the incidence of chronic wounds, including pressure injuries, is increasing as the population ages. Clinical presentation. The severity of pressure injury can be estimated by observing clinical signs. A progression from least tissue damage to most severe damage is presented here. More details on the challenges of identifying pressure injury depth will be covered later in the chapter. The first clinical sign of pressure injury is blanchable erythema along with increased skin temperature. If pressure is relieved, tissues may recover in 24 hours. If pressure is unrelieved, non-bleachable erythema occurs. Progression to a superficial abrasion, blister, or shallow crater indicates involvement of the dermis. When full-thickness skin loss is apparent, the ulcer appears as a deep crater. Bleeding is minimal, and tissues are indurated and warm. A scar formation marks full-thickness skin loss. Tunneling or undermining is often present. The official staging classification for pressure injuries will be covered later in this chapter. The majority of all pressure injuries develop over 6 primary bony areas. Fig 14.7, sacrum. Figure 14.8, coccyx, greater trochanter, ischial tuberosity, calcaneus, heel, and lateral malleolus. History. If an individual has a history of a period of immobility followed by the discovery of a warm, red spot over a bony prominence, a pressure injury can usually be confirmed. If the spot is unnaturally soft to the touch, sometimes referred to as boggy, this is enough evidence to suspect that damage is deeper than the epidermis. Tests and measurements during examination, along with general wound characteristics. Pressure injuries are classified by grading or staging systems that describe the degree of tissue damage observed. It can also be important to use a tool to measure an individual's risk of developing a pressure injury before a tissue injury exists. Refer to the Integumentary Integrity section for more information on risk assessment for pressure injuries. Figure 14.9. Intervention. A physical therapist treats integumentary disorders that involve the epidermis, dermis, hypodermis, or billow into exposed bone, tendon, muscle, and organs, for closure and subsequent healing to occur. Intervention for disorders of the integument must facilitate local and regional homeostasis of the vascular and lymphatic systems. In addition to appropriate wound care, it is imperative that the underlying cause of pressure be addressed. Wounds will not close and remain healed unless the reduction of pressure and prevention of future breakdown are top priorities in the intervention plan. Pressure management is accomplished with the use of PRDs, pressure mapping to determine pressure loads, positioning turning schedules, and education of the patient, family, and caregivers. Other factors that contribute to ulceration or risk of ulceration should be considered and are addressed. These factors include shear, friction, mobility, sensation, moisture, nutrition, age, and underlying medical condition. With appropriate wound care, control of pressure, and attention to risk factors, a wound should progress through the phases of wound healing, showing signs of improvement in a matter of weeks. Neuropathy. Neuropathy can be defined as any disease of nerves and can include peripheral nerves, cranial nerves, and/or autonomic nerves. Neuropathy exists in many disease processes. However, the most common disease process seen with neuropathy is diabetes. For most chronic diseases, including diabetes, the effects of neuropathy are peripheral. The etiology of diabetic neuropathy is not well understood but thought to be related to high levels of glucose in the blood over a long period of time. Diabetic neuropathy is a generic term for any diabetes mellitus-related disorder of the peripheral or autonomic nervous systems or the cranial nerves. The majority of symptoms from diabetic neuropathy will be located in the leg, with foot insensitivity and subsequent ulceration being the most common. Figure 14.10. It is estimated that 15% of individuals with diabetes will develop a foot ulcer sometime in their life, making them almost 40 times more likely to undergo amputation because of a non-healing wound than the non-diabetic population. To complicate matters, many individuals with diabetes have coexisting arterial disease because the conditions are not mutually exclusive. Although the incidence is lower than for venous and arterial wounds in general, the underlying diabetic condition creates a difficult environment in which to close a wound. The incidence of neuropathically wounds is likely to grow as the population ages and the incidence of diabetes continues to escalate. According to the Centers for Disease Control and Prevention (CDC), almost half of all adults now are at risk for diabetes. Diabetes affects more than 29 million people of all ages in the United States. This figure represents 9.3% of the population. About 60% to 70% of people with diabetes have mild to severe forms of neuropathy, and more than 60% of the non-traumatic lower limb amputations that are performed in the United States occur among people with diabetes. 80 if current trends prevail. The impact of diabetic neuropathy on future wound care needs will continue to expand. Clinical presentation. Ulceration is usually located on the weight-bearing surfaces of the foot, usually anesthetic, round, over bony prominences but can be located anywhere. Sensory neuropathy, if present, common patient unable to sense pain and pressure. Risk of skin breakdown without patient awareness. Mechanical, repetitive stress is most common causative factors of wounds. Motor neuropathy, if present, loss of intrinsic muscles, hammer, toe, claw-toe deformities adding to risk of breakdown owing to poor weight distribution and rubbing from shoes. Foot drop, autonomic neuropathy, if present, decreased or absent sweat and oil production leading to dry, inelastic skin, increased susceptibility to skin breakdown and injury, propensity for heavy callus formation, dysvascular symptoms, if present, common usually arterial disorders but can be complicated by reduced cardiac function from autonomic causes.
Ischemia.
Impaired healing time, also present owing to diabetes, impaired transport of oxygen, antibiotics, and nutrients needed for healing. History. A history of diabetes is sufficient to warrant investigation of diabetic neuropathy. If the individual has had diabetes for a number of years or has had trouble regulating insulin levels even for a few years, the presence of diabetic neuropathy is very likely. When ulceration is visible, the history will include specific details about the wound in addition to information about other symptoms, tests and measurements during the examination. Every patient with diabetes should be checked using monofilaments for the presence of protective sensation in the lace. This should be part of the system's review for patients with diabetes even when diabetes is not the primary diagnosis. Data on skin temperature of the lace should also be recorded during the examination. Information about blood glucose levels should be obtained as part of the examination and must be considered for safe development of the POC. Intervention. Physical therapists are in an ideal position to provide education and comprehensive foot care intervention for the diabetic population. In addition to appropriate wound care and maintenance of acceptable blood glucose levels, intervention must include some method of decreasing weight-bearing stresses. Options for offloading include crutches or walker, changes in gait patterns, walking casts or splints, and specialized footwear. It would not be unusual to utilize all of the offloading options over the course of treatment for foot ulceration. Intervention must include a comprehensive program, including elements of wound care, foot care, education, PRDs, orthotics, exercise, and modalities. Every effort should be made by clinicians and patients alike to improve or retain skin integrity of the foot. Refer to Appendix 14A for patient education information on foot care. In addition to other medical complications of diabetes, altered circulation to the foot can complicate symptoms from diabetic neuropathy. Intervention should address the worst problem first but with lower expectations for healing when vascular disorders coexist with neuropathy. The 5 most common disorders of the vascular, lymphatic, and integumentary systems have been discussed. Other disorders caused by surgery, trauma, malignancy, hematologic disease, connective tissue disease, and thermal injury will affect the systems discussed in this chapter. Owing to space restrictions, however, they will not be discussed at this time. Interested readers should seek one of the texts mentioned in the reference list to supplement information presented here. Examination and treatment of other disorders would utilize the same tests and measurements and treatment interventions discussed in this chapter based on the patient's unique characteristics.
Okay, that is all of the reading. 1 hour and 14 minutes. So we are going to do a part 1 and a part 2 of this day. Part 1 is going to have the readings from the Big Red Physical Rehabilitation book, and part 2 will be on the therapy